Evening. I'll be talking about the robotic arm for the angioplasty. Basically, we all know that whenever it comes to angioplasty, it's a guide wire, balloon, and then putting a stent. And now today we are talking for the last 2 years about the robotic assisted angioplasty. I'll be sharing my experience with you all. It was a precise clinical trial where they used the CorePath 200 system for 164 patients, and they found that it's a 97% procedural success, 98% device technical success, and the most important thing was there was a reduction in radiation exposure to primary operator. This is basically a JREX vascular robotic system. It's a second generation CorePath platform, increased precision, improved workflow, extended capability in complex procedures, and basically designed to improve procedures for physician and staff. Active guide catheter management, robotic control of guide wire and rapid exchange catheter. There is a extended reach arm and basically a 40-inch power vision monitor. You can see here it is a robotic arm which we can see, and there is a console where we can sit and manage the guide catheter, guide wire, and then the balloons and the stents. Uh, when we talk about yeah, when we talk about a robotic assisted PCI, I think the ergonomic visualization as the monitor is very nearby. Then whenever we are doing a navigation, I think point and shoot capability is there. Wire movements we can do it with a properly with joysticks. Then the sub millimeter measurement or millimeter measurement are good with a robotic assistant. Then 1 millimeter precise positioning of the stent can be done, and as we can fix the guide catheter and guide wires, the longer stents or the stents can be easily pushed distally or in the tortuous vessels also. So precision, what I was talking about, the longitudinal miss, many times we see that whenever we are trying to put a stent and what measurements we do, so sometimes with the corners or the length measurement becomes the issue and we miss certain things. So here that was a case where visually we were thinking of around 35, 36 millimeter length, but on CorePath we found that it was 28 millimeter, and you can see with 28 millimeter stent we got a good result, so that the stent length and the stent usage went down. And most important thing I think in the robotic angioplasty is basically a radiation exposure for the operator and the other staff. We all know the increased radiation exposure, brain tumor risk is increased risk of cataracts and carotid atherosclerosis and early vascular aging. And mostly I think the orthopedic strain and the fatigue, and that is almost spine issues. After 21 years of practice, spine problems in 42% in the general population, but it is 60% in the cardiologists, and the 33% missed work due to the orthopedic issues. So I think that is the one of the most important in radiation protection what we see. In CorePath, you can sit and do the procedure. There is a console where the radiation shield and everything is there, so that whenever we are doing a plasty, I think the radiation is a main issue, and that's what is prevented. And you can see that the staff is reduced and the staff is standing at the third or fourth position, and because of that the scattered radiation for the nurse and technician also reduces. Uh, Complex procedures, yes, this was the first trial, Cora PCI trial, 334 procedures, 108 robotic and 226 manual PCI. Success rate was almost 91% and the 99% clinical success. So in type B and type C lesions also the robotic angioplasty can be used safely. I think the radial requires a lot of learning curve is there. So initially the radiation is on higher side compared to femoral, so that the radiation exposure goes, and the left radial approach, you are bending, you are trying to do the catheter placement, that becomes a tedious job where the robotic arm can help us if the right approach is not there. And the orthopedic strain, as we talked about, long hours, as nowadays we are doing more complex procedures, the orthopedic strain also can be reduced. This is basically a robotic arm where you can see a Y connector can be connected. This is the small display which guides you how to fix the catheter, how to fix the wires and the you can give the commands from this small display. It's a device manipulation is good, precise actuation, multiple device control, two wires, two balloons we can use in it. Automated wire techniques, this is what they have added in the last 6 months for the chronic total occlusion. What movements we do with our fingers, the same can be achieved with the robotic assisted. And the tele-treatment, I think that Dr. Tejas Patel performed the first intracity robotic angioplasty at 30 kilometer distance. And basically artificial intelligence where the peri-procedure lesion assessment, treatment plan and device selection can be planned. I'll show you some cases which I did in the last 2 years. So basically the around 150 robotic cases we completed. Type A 45%. It was the initial period we used to take only a type A procedures, then type B and the type C it's 40% and 15%. This is how the we do a loading of the wires, balloons, and that's what I'll show you. This is a long stent which we used with a robotic arm. You can see a robotic arm. The Abbott Y connector is used, which can be fixed very well on the robotic arm. Wire is there across the Y connector. You can see these are the rotors which are there, which moves the wire and the balloon. See, these are the rotors where the balloon is kept, and these are the other rotors where the wire is kept. There is a plug where the wire can be fixed. You can see that there is a turbo button in the robotic arm. Once you load the balloon or the stent with a turbo button, you can take the balloon from the distal end of the catheter to a proximal end of catheter in few seconds. You can see with turbo button this balloon is moved. So this is how you can move the balloon stents. This is the console where there are three joysticks. One is for the guide catheter, one is for the wire, and the third is the balloon and the stent. The guide catheter and guide wire, I think antegrade, retrograde movements are there. 180-degree movements we can achieve, and that's how we do a robotic plasty with these three joysticks. This was a long stent robotic PCI patient of a diabetic, came with an inferior wall infarct, thrombolized but persistent pain, in shock with raised creatinine. She was transferred in night to Magnum, where we did a angioplasty. It was a 100% occluded artery. After wiring, you can see some flow. This is how the stent was loaded on the arm. We were sitting and the long stent was deployed. As the catheter and the wires were fixed, it was easy to deploy, push the stent through the proximal to distal part, and this was the good result. Similarly, the ostial lesions, I think when we are worried about the 1 millimeter movement, I think the robotic really helps us. With one touch of button, 1 millimeter movement, antegrade or retrograde, we can do it. And this was the patient came with unstable angina. You can see ostial LED lesion. So we just kept the marker over here and the movements of 1 millimeter. When we do a ostial lesion and we want to put a stent at the ostium only and without to Lepman to LED, I think 3-4 times manually and lot of shoots we have to take, where it can be avoided, and you can see that the proper placement of the ostial stents can be done. This is again the 46-year-old male, thrombolized but persistent ST depressions and STT changes, and he was transferred for the further procedures. When we did the angio, it was again a RCA 100% occluded. Then again we dilated with a balloon and the 48 millimeter stent was deployed, and this is how the RCA lesion is there. So this is how I think the pushability of long stents, fixing of the catheters and the wires for ostial lesions or the placement of the stents, 1 millimeter movements can be done very well. And if we look at the type A to type C lesions, I think what are the timings we require for doing the procedures? It was initially it was more because the team was getting to be trained, arranging the robotic arm, loading the wires and balloons. But after once we got used to it, we started doing the type B, type C lesions also, long stents, where we did some 1 or 2, 3, 4 bifurcation lesions, where the one wire, one balloon can be managed and can be kept aside, and the other wire balloon can be passed through the rotors, and that's how we could do the bifurcation lesions also. So overall, I think it is a good experience. It is basically you can sit and do the procedure, and that's really a comfort. Monitor is just in front of you so that the visual visibility is good. And that's why I'll say that the robot assisted PCI systems improve operator safety, basically reducing the ionizing radiation exposure, and can improve the procedure quality and outcomes by offering better accuracy in stent selection, positioning, and the delivery. So in the last 2 years, because of COVID, in last 8-9 months, cases were less, so we did a less numbers. But overall, 160, 170 cases we have done in 2 years, and yes, it's a good device, but I think we'll need a more centers, more studies. Really, it will replace and it will help us in our angioplasties. But I think for reducing the radiation and the orthopedic problems, it's a very good device and which can help us in reducing our radiation and the orthopedic problems. This is all about the robotic angioplasty and my experience in last 2 years. I thanks organizers for this.
Okay, thank you, Manoj, for sharing your experience regarding the robotic assisted PCI. Just I am asking two questions to you. Firstly, what is your experience regarding in the acute setting, STEMI or non-STEMI?
Basically, sir, as I showed some 3-4 cases, they all were STEMI cases actually. And in those patients also, we use the robotic arm. Basically, yeah, we were means no flow phenomena. If it is there and if it takes time, then it's a worrying factor. I think in overall our 160, 170 cases, we converted to a manual in 5 patients where no flow, patient getting hemodynamically unstable, and there we were worried that we will be able to manage it or not. I think these 4-5 cases we had to convert it to manual. That was in an early stage, but later I think once we are used to it and we know that how to manage these things, the team is also experienced about that. So I think we are doing those acute STEMI and non-STEMI also.
Okay, thanks. Another issue is in the COVID era, how it would be beneficial if a COVID patient, I mean the PCI, RT-PCR positive patient.
Yes, I think, sir, that is really basically in COVID era, it really helped us in many RT-PCR positive patients coming with the STEMI and the non-STEMI. We did almost around 20-25 cases in this COVID era. Patients coming there, we use robotic. Basically, the human touch is not there. Only one technician was involved preparing the robotic arm, putting the catheters and wires, and we could complete the procedures. So in I think COVID era, it has really helped us because we are away from the patient and the exposure was reduced.
Thanks. Any other comments from?
Yes, Dr. Manoj. Can I make
Dr. Manoj?
Yeah. Praveen, yes, Praveen.
Yeah,
You give your comments,
Yeah.
Praveen.
Yeah. So I must congratulate Dr. Manoj for doing such a fantastic work in Nasik. And we are still wanting to look at this device, but he has done so many cases very successfully.
Yes.
I think every technology has its own niche. And we understand that you don't need to do in every case because the cost goes up and all that. But definitely the niche value of this technology is immense, and maybe it improves further. So then we'll have more, usage, and definitely it will be very, very beneficial. Thank you, Dr. Manoj. I think you did a great job. Congratulations.
Thank you, sir. Thank you.
Okay. Any other comments?
Manoj and Dr. Panja here.
Yes, sir.
So my question that it cost, how much cost is?
It's around 4 crores, sir. 4 plus.
Oh my God, it just double.